Hi, this is Dibya Prakash from nuclearmedicinesolutions.in, and in this part of presentation we are going to see about the CT dosimetry in nuclear medicine. In the other two parts we have already discussed about the importance of dosimetry in nuclear medicine, and the radiopharmaceutical dosimetry we have also seen. In this presentation we are going to see about the CT dosimetry. So let's begin. This kind of radiation report we used to get from the machine, where the machine says that this much of scan area is being scanned, has been scanned. There are terms called CTDA wall, DLP, phantom. These all the terms are used in this report. This is a typical dose report which was generated from 16 slice PET CT and using vertex to mid-thigh protocol, and this is the dose report of that protocol. The second dose report is obtained from the eye to thigh plus brain protocol, and the third dose report is obtained from the triple phase vertex to thigh protocol. So we will be calculating practically to these dose reports. This is equivalent to how much of effective dose to the patient, and we'll be seeing all the terms which are used in this dose report. So just by seeing the common sense how a CT dose can be calculated is, one, the intensity of CT beam which is falling onto the patient, that will have one factor, and the length or the area which is being covered by the CT machine for the scan, and the diameter of the scanned object, means patient is thin or it is he or she is fat. So that also matters a lot when we are discussing about the CT dose. It can have around 2 to 3 times if the patient is thinner, and it can be half if the patient is very heavy or the fat. So if this is the dose report where which we receive from the machine, this contains the terms scan range, CTDA wall, DLP, and the phantom. Then what account for what? So CTDA wall is the intensity of the CT beam. So CTDA wall, why we are getting this? Because it is saying the intensity of the CT beam, and this includes the kV, MA, all the factors we will discuss in the next slide. DLP is covering the intensity of the CT beam as well as the length of the scanned area, means it is dose length product which includes CTDA wall into the length of which it is being scan area is being covered. And the third is phantom, means which phantom is used for the dosimetry purposes. They can have a different, means if it is a brain phantom then it will have 16, and if it is a body phantom it will have 32 centimeters. We will discuss in detail in the forthcoming slides. Let's see what is CT dose index. It is a standardized measure of radiation exposure delivered by the CT scanner during the single rotation, and it is not the actual absorbed dose received by the patient during an entire scan, but rather an index that allows for the comparison between different scanners and scan protocols. It is generally a weighted average of peripheral and the central dose indexes, and the pitch, which means what speed the table is moving in comparison to the CT head which is rotating around the patient. And this CTDI wall depends upon several factors that includes the tube voltage, that is kV, tube current, MA, tube rotation time, and CT pitch, and the phantom size. And this is independent of the total scan length, and is a universal matrix that talks about the intensity of radiation incident on the patient and do not represent the patient dose. So it is only the output of radiation which is coming from the machine, it is a measure of that. So if we output is multiplied with the length, then it becomes absorbed dose to the patient, and this DLP is a product of CTDA wall into the scan length, and it is proportional to the total doses imparted to the patient, and it is a good indicator of total amount of radiation incident on the patient, and it is directly related to the patient stochastic risk and may be used to set reference values for a given type of CT examination to achieve a LARA concept, and it is measured in milligray into centimeter, as it contains both the factors length as well as CTDA wall. See, a CTDA wall for this is 20 milligray, for this also it is 20 milligray, and for this scan length also it is 20 milligray, but the length which it covers is L1, L2 and L3, and both are different, so the DLP values will be different, and DLP1, DLP2, DLP3, both, all the three will be having different values, though CTDA wall was fixed for all of them and it was constant in all the conditions. Now coming to the CT dosage phantoms, so there are generally two sizes of phantoms are used: 16 centimeter adult head phantom and the 32 centimeter diameter adult body phantom. The 16 centimeter adult head phantom is equivalent to a pediatric body phantom, which is of 2 years of old pediatric size. For that also it can be used, and both these phantoms have a length of 15 centimeter and they are made up of polymethyl methaacrylate, that is PMMA matter, and traded with different names like lucite, perspex and plexiglass, kind of that. There are different phantoms can be there which can be used for different ages of the patients, like 10 years, 15 years, 20, 5 years newborn kind of things, and they have density of 1.185 gram per centimeter cube, and they have around 12 mm of diameter holes at the center and at the periphery to account for CTDI wall, which we are just saying that periphery and center factors, both factors were being used, so they have holes of 12 mm diameter. In APM report 200, which was published in 2020, APM and ICRU they both gave this phantom, and this phantom has density of 0.97 gram per centimeter cube, and it is made up of polyethylene, and it is cylindrical in shape, of 30 centimeter in diameter and 60 centimeters in length. When we talk about different sizes of the patients, the size matters a lot when we are calculating the dose, and APM comes out with the solutions for this size specific dose estimates, that is SSD term they used, and in practice they say that there is a wide variations in the patient sizes, and size variability among the patient may significantly change the absorbed doses, which can be around 2 to 3 times. And to account for size variability, they have provided some detailed guideline in APM report 2004, which was published in 2011. This is the size of the patient, which can, if horizontally and vertically, if it is divided, then it can be called as a AP dimension and the lateral dimension, and the total area can be this much, which from where the effective diameter can be obtained from under root of AP and lateral multiplications. They give some table for which can be used for different sizes of the patient. They are ready to use tables which can be used while we are doing the calculations, and it contains the lateral plus AP dimensions and the effective dimensions also it is calculated, and they give these conversion factors. If the patient is having a diameter of 16 centimeter, the conversion factor will be used as 2.79, means the radiation dose to this patient will be almost 2.79 times more than the normal patient, which is considered as a standard patient. And if the patient is very bulky kind of, so the conversion factor will be 0.72, means the radiation dose will be lesser than the normal people. This is for the adult body. This is using adult body phantom, and 32 centimeter diameter PMA phantom is used, and then this table is designed. Similarly, for the 16 centimeter diameter PMA phantom, this table is also designed, so this can be used when we are using 16 centimeter diameter phantom. This table can be used. They also provide one table where they give if the patient age is this so they can be considered as effective diameter this much, and this way we can simply calculating seeing the effective diameter, we can get the conversion factors from those tables. There is some conversion factor directly which can be used for the effective dose calculation, and we receive the DLP doses from the dose report, and if you multiply this conversion factor, we can directly get the effective dose of that organ or the equivalent dose of that organ or the effective dose to the whole body. And this was published in AAPM report 96, and they give different ages of patients and different conversion factors. If they are directly multiplied with the dose DLP value, we can, and if you multiply with the size specific dose equivalent, these all three will combinedly called as a SSD, combinedly called as, they will combinedly give effective doses for the patient. This paper, which was published by Huda et al. And published in 2011, and this was published in 2014, and they give conversion factors for that are, those are based on ICRP-103 recommendations, and they are using tissue weighing factors which was given in ICRP-103, and they have values of whole body and the values combinedly for chest, abdomen, pelvis, and for the lower extremities. These all the values which can be useful for us while doing the PET CT, because as we are doing whole body, so these conversion tables, conversion factors can be used while we are doing the CT dosimetry in PET CT. So let's calculate CT doses which we obtain the dose report from the machine. Here, for the simplicity, we are considering patient as a normal patient and considering the size specific dose estimate as factor as 1. And when we calculate, let's just see the DLP value for HRCT thorax, because this reading corresponds to the thorax area. So this is DLP for the thorax, and the second DLP is for the whole body. The effective dose for the HRCT thorax will be 5.6 millisieverts. Similarly, for the whole body, it will be 18.2 millisieverts, and the total effective dose will be 23.8 millisieverts. And just have a look, this is for the vertex to mid-thigh protocol PET CT dose report. When we are going for the eye to thigh plus brain protocol, the dose report, whatever it comes, this accounts for the brain data also. So we'll multiply the conversion factor with the brain, and now the dose will become 25.4. So just have a look, this was 23.8 when we are doing vertex to thigh protocol, and it becomes 25.4 when we are doing eye to thigh plus brain protocol. This is almost 10% of difference is there. But why this difference is there? Because same length of patient was scanned, just because certain areas gets overlap between these two protocols, so we are getting more doses. So we should be careful while designing which protocol should be used for the which patient. This is the 3 triple phase PET CT protocol obtained dose report, and if you are calculating, this is the dose report is 37.3 millisieverts. The total effective dose is coming. The value is almost 1.5 times what we obtained in the eye to thigh plus brain protocol. It is more than 50% doses what we obtained in vertex to thigh protocol and what we obtained in triple phase CT protocol. So just see how much dose increases to the patients and what is the importance of having a careful determination of protocol selection. I'm comparing on this slide, so just have values. So this method of calculation of effective doses is not very accurate, but though approximation can be done, and we can get a good approximation, but it is not considered as a gold standard. So there are two methods of calculating radiation doses from the CT. One is called gold standard method, which uses Monte Carlo simulations and the tissue weighing factors from ICRP-103 recommendations, and the other method is this, which we used dose conversion coefficients, which we can directly multiply DLP with the dose conversion coefficient, and we can get the effective doses. In the gold standard method, this There are softwares are also available, but this sheet can be obtained freely from online, and organ dose estimates can be done, and this uses the NRPB, that is National Radiological Protection Board UK multicolor data set, and calculated by the impact Excel worksheet, and it can also be used some other softwares, but this is freely available. This sheet can be downloaded from the internet, from the website impactscan.org, and the codes can be obtained from the UK government by mailing on this mail ID, and simply we can get the effective doses to all the organs, simply just putting the values, selecting the machine name and the tube current what is used. So they are precise, but they are little time consuming, but they are easier. So if you wanted to go have a precise readings, this method can be used, and this is also freely available. So thank you so much. Hope this series is helpful to you all. Thank you so much.